This is going to, thank you. This will be a jam-packed day, so we'll just go ahead and get started. But before we begin today, I just want to have a few housekeeping items addressed. First of all, we are recording, as you may have heard, and a link will be posted on our Community Solutions YouTube channel. Slides will also be made available after the program's conclusion, so don't worry, you'll have access to all the content that we will show you here today. We'll also have time for question and answer, and we ask today's attendees to please place those questions in the chat where CCS, us at Community Solutions, will help facilitate, though you may get asked questions throughout the presentation, so feel free to respond as you are able. So thank you for understanding and joining us here today. My name is Loren Anthes, and I'm a senior fellow and Troy Hoff Chair for Health Planning at the Center for Community Solutions. We're a nonpartisan, nonprofit think tank focused on solutions to health, social, and economic issues, and I'll be today's moderator and host. Welcome to today's event. As many of you may know, Medicaid covers about 1 in 4 Ohioans, 1 in 2 births, and is responsible for the majority of care for the elderly and disabled. Representing over about 4% of Ohio's GDP, it is important that consumers, advocates, and providers stay up to date on the policy developments of one of Ohio's most significant and confusing safety net programs, also confusing and complex just generally in the United States, which is why we have the Center for Medicaid Policy here at the Center for Community Solutions. From its founding in 2015, our goal was to address and increase the capacity of Northeast Ohio's health delivery system to effectively engage in Medicaid policymaking at the local and state levels through effective and timely research and analysis. Today's webinar is one in a series we call Medicaid Institutes, where we do a deep dive into a specific aspect of the Medicaid program. And today we are talking about hospital community benefit programs. So why are we interested in this? Well, yesterday, Community Solutions released a piece entitled Anchor Institutions, How Hospitals Can Hold Local Economies Down and the Case for Reforming Community Benefit. In this piece, we outline how the often confusing and complex community benefit standard came to be and what it entails. As you can see in some of the data we have here, over 58% of the $5.1 billion in Ohio's community benefit pool is actually Medicaid shortfall, an ill-defined metric that may actually reflect price more than it does cost, thereby bringing into question, where does that other 42% go, why, and what policies could be developed to better support local communities and their overall health and well-being? To help us think through this question, let me introduce you to our guests from the City of Cleveland and the Lown Institute. First, I want to introduce Dave Margolis. Dr. Margolius, before we hand over the things to Lown, I want to introduce everyone here and offer him a few minutes to offer some perspective from the City of Cleveland about some of their activities. On June 8th, Dr. Margolius was appointed the City of Cleveland's new Director of Public Health. He's an active educator and he's Associate Professor at the School of Medicine with Case Western Reserve University and faculty co-lead for the Medical Director Leadership Institute at Harvard Medical School's Center for Primary Care. Dr. Margolis has been published in numerous peer-reviewed journals on a wide range of public health topics, from COVID-19 response in underserved communities and the opioid crisis to hypertension in low-income populations and best practices in primary care, preventative medicine, and family medicine. He also regularly sought out by both local and national media for his experience regarding the complexities of today's public health environment and the myriad challenges facing physicians in primary care. Dr. Margolius holds an MD from Alfred Medical School at Brown University and a BA in biology from Brown. He completed his residency in internal medicine at the University of California in San Francisco, where he spent his last year as chief president of quality improvement and patient safety before returning to the land, Cleveland, and joining the Metro Health System. He lives with his wife and his 2 children in the Brooklyn neighborhood of Cleveland. Dr. Margolius, thank you for joining us today. If you don't mind, would you like to offer a few thoughts on the discussion today?
Thank you, Loren. That was a very kind introduction. And the most important part is that I played baseball in 6th and 7th grade with Loren growing up in Shaker Heights. So it's been really nice to have the warm welcome back. When I came back to Cleveland in 2015, we got to work with Loren a couple weeks before he left Metro for Center for Community Solutions. So as Loren mentioned, so I was appointed Director of Public Health, City of Cleveland in June. I started in the role in August to give to really, hang out at Metro as a lame duck for a couple months. So I appreciate all the Metro folks I see on the call today. I came to the health department, so really with a vision. And it's an incredible group of people here. And I just want to tell you a little bit about the work that we do. So our vision that we're drafting out now is to be the most responsive, most trusted, most impactful health department in the country. In terms of being the most responsive, much of our work is in the scope of helping folks through code violations, helping to abate nuisances. And so when folks reach out to us, which they often do, and disproportionately the areas of Cleveland that are most affected by nuisances are on the east side of Cleveland, it's predominantly black side of Cleveland from historic redlining. We want to offer same-day resolutions. Most trusted means that when folks in our community need health information, we want to be that source of information. And all respect to all the healthcare colleagues on the call today, the public health department for the city of Cleveland wants to be that number one call, that number one source of information, and we can all collaborate to put together that information. But hopefully you'll see a lot more of us on local media and out in the community. Most impactful. So City of Cleveland has some of the worst health outcomes in the country. And we're going to own that and mend that. I'm going to list a few of them and just to depress you all. So the City of Cleveland has one of the highest smoking rates in the country. 35% of adults in the City of Cleveland smoke cigarettes. Smoking is the leading preventable cause of death in the United States. At its peak, COVID took 300,000 lives in 1 year. That same year, tobacco took nearly twice as many people from us. And so if we haven't improved that smoking rate from 35% to the national average of 12.5%, then we haven't done our job at the health department or the health, all of us involved in health in the community. Black infant mortality rate, as many folks will know, is nearly 4 times as high as our white infant mortality rate in Cleveland. It's incredibly high at nearly 15 per 1,000 deaths dying before the age of 1. Lead poisoning rate in the city of Cleveland in 2017 was 12.5% of all lead tests sent were positive for lead, causing irreversible damage to our children's brains. And gun violence. So over the last few years, our incidence of gun violence causing harm to humans, public health, has nearly doubled and has been extraordinarily high well, I won't give you the exact numbers, they're depressing. And then lastly, I'll just mention opioid overdose deaths. So Ohio, as many folks know, has been kind of ground zero for the opioid epidemic. Cleveland's rate of deaths from opioid overdoses is 4 times as high as the rest of the state, and it's rising. So those are just a few of our priorities at the health department and ways that we want to be the most impactful by reducing those dramatic disparities and causes of morbidity and mortality in our community. And I look forward to partnering with the healthcare community and other stakeholders to take these on. But we haven't done anything if we haven't made a dent on those metrics. So with that, Loren, I'll turn it back to you.
Thank you, Dr. Margolis, and thank you for those thoughts. I think it's great to see you in this position of leadership with the department and the focus on the areas that you are, because I think community health requires that sort of big level strategic thinking, and hopefully the conversation that we're having today can build on the sense of collaboration that you're outlining for all of us. So really do appreciate that and appreciate those thoughts. I will get back to our guests now from the Lown Institute, who are going to provide us with the main content for today's event. And for those of you who are not familiar with Lown, they're one of the premier health system nonpartisan research organizations in the United States, with a mission built on engendering equity, healing and patient-centeredness in our delivery system. And if you're not familiar with them or their work, please visit their website at www.loweninstitute.org. But before I hand it to them, let me make some general introductions. First, Judith Garber. Judith is a senior policy analyst at the Lown Institute. She joined the team in 2016 after receiving her Master's of Public Policy from the Heller School of Social Policy. Her research interests include hospital community benefit policy, overuse and land value-based care, and racial health disparities. She's authored several white papers, journal articles, op-eds, and other publications on these topics. Previously, she worked at the Aspen Institute Financial Security Program, the Midas Collaborative, and Pearson Education. She has a BA in American Studies and Political Science from Rutgers, and in her free time, Judith enjoys playing competitive ultimate frisbee and listening to musical theater. Welcome, Judith. We also have Vikas Saini. Dr. Saini is president of Lown Institute. He's a clinical cardiologist trained by Dr. Bernard Lowndes at Harvard, where he has taught and done research. Dr. Saini leads the Institute's signature project, the Lown Institute Hospitals Index, the first ranking to measure hospital social responsibility. The index, first launched in July of 2020, evaluates hospitals on equity, value, and outcomes, and includes never before used metrics such as avoiding overuse, pay equity, and racial inclusivity. In his role at the Lown Institute since 2012, Dr. Saini led the development of the Right Care series of papers published by The Lancet in 2017, convened 6 national conferences featuring world-renowned leaders in healthcare, and guided other Lown Institute projects such as the Shkreli Awards. Dr. Saini also serves as co-chair of the Right Care Alliance, a grassroots network of clinicians, patient activists, and community leaders organizing to put patients, not profits, at the heart of healthcare. Prior to joining the Lown Institute, Dr. Saini was in private practice in cardiology for over 15 years on Cape Cod, where he also founded a primary care physician network participating in global payment contracts. He also co-founded Aspect Medical Systems, the pioneer in non-invasive consciousness monitoring in the operating room, the BIS device. He's an expert on the optimal medical management of cardiologic conditions, medical overuse, hospital performance and evaluation, and health equity. He has spoken and presented research at professional meetings around the world and has been quoted in numerous print media, radio, and television. Welcome, Dr. Saini. Now, without further ado, I'll ask our guests to share their slides and start the presentation. A reminder, if you have questions, please place those in the chat, although we will get questions prompted to you throughout, and we'll get to them at the end of the presentation. So I'll stop talking and hand it over to the two of you. Thank you.
Great. Can everybody hear me? Yes, excellent. So let's get started. I won't belabor who I am, but let me just say I have a connection to Ohio, though not Cleveland, since when I landed in America at the age of 4, a long time ago, I landed in Columbus. So I was a lifelong Buckeyes fan, at least until I got to college, when I sort of obliged to root for my own team. So thank you very much, Loren. I'm delighted to be here. Really, it's a privilege to speak to you all. I'm happy to share our work. Dr. Bernard Lowndes, some of you may know, but many won't, was a remarkable physician. Though I'm biased, I'd say he's really one of the leading physicians of the last 100 years. He developed the first defibrillator in 1960, and actually have a letter from the head of the Cleveland Clinic cardiovascular surgery program to Bernard saying, "Without you, none of this would have been possible." He also was an activist in many different dimensions and actually won a Nobel Peace Prize for his work in anti-nuclear physicians movement. He was the founder of our organization, and really a lot of our approach and worldview derives from his very broad, deep vision, both for the world and healthcare in particular. So the Lown Hospitals Index for Social Responsibility is a project we've been working on for quite a few years. We asked ourselves a rhetorical question. 100 years after Abraham Flexner wrote his report that transformed American medicine and really pushed the idea that science and scientific practice needed to be a fundamental part of training and practice, we asked ourselves the question, 100 years later, can we reframe what it means to be a high-performing hospital, because a lot of water has passed under the bridge in 100 years. There have been a lot of changes. And while nobody would dispute the need for the scientific basis for what we do in medicine and healthcare, there are many other considerations really that need to come to the fore. So we view the Lown Hospitals Index as landing right in the bullseye, at the intersection set of three important dimensions of the work as we see it. That's promoting health equity, promoting value in healthcare, and accountability. And for us, accountability means real accountability to local communities and the civilian population, if you will. So the Lown Hospital Index for Social Responsibility is a tree. There are three major branches that lead to our annual ranking. Those are equity, value, and outcomes. But as you see that underneath those, there are quite a few additional metrics. And each of these have lower values in turn. For instance, clinical outcomes, a standard one that pretty much everybody reports, includes mortality, readmissions, and patient satisfaction includes HCAHPS. And this year we're going to be using outpatient assessments for the first time. So it's quite a comprehensive approach. There's a lot of data we use. It's all publicly available. It's transparent. Anybody could do this if they decided to spend 3 to 4 years and several $1 million to put this together. So we don't have any special kind of sauce. We just have a point of view and what we're trying to achieve. So today, of course, the focus is on community benefit. So I'll share with you a little bit about what we've been doing there. And Judith will also give you a lot more perspective, since she's really our domain expert at the Lown Institute on this issue. So Judith, what is community benefit?
Thank you, Vikas, and thank you, Loren, everyone, for having us today. We wanted to sort of pose this question for everyone also to put in the chat if you're so inclined. What do you consider community benefit? What are actions that are beneficial to your community that hospitals can do? And while you think about that question and maybe put your answers in the chat, we'd love to see them. I'm going to go into a little bit about what the IRS Community Benefit Standard is. So the IRS Community Benefit Standard, it's been renegotiated and redefined several times over the last, more than 100 years. Since the income tax has been instituted, charitable institutions have been exempt, but it wasn't codified in law until the 1950s, and in which the IRS required hospitals to provide free and discounted care to people who couldn't afford to pay to the best of their ability, the best of the hospital's ability. That's sort of what the standard was. Then in 1969, during the Nixon administration, that changed to be more general. It wasn't just provide free and discounted care. You could provide anything that was beneficial to community health. It was a very nebulous definition. And as our friend Sarah Rosenbaum, who does a lot of this research from the George Washington University, she said, the Nixon administration said to hospitals, you all just do things you believe will benefit the community and we'll give you tax exempt status. So it's a big deregulatory move. Then in the 2000s, we had a shift back. In 2008, hospitals were required to file Schedule H, which included all the different types of community benefits. And these types and definitions were a political process. The IRS didn't just kind of sit down and create these. They had a lot of input from hospitals, and it was a negotiation over what should count on this IRS form as a community benefit. For example, Medicaid shortfall became one of the categories included by the IRS. Medicare shortfall did not, and bad debt did not. And the reasons why are kind of more political in my mind than anything inherent in what those categories mean. It's also worth noting that there's still no federal minimum amount of community benefit spending required at all. It's just you have to report it. And the spending, although hospitals are required now by the ACA to create a community health needs assessment every 3 years, the spending that they do in the community benefit realm doesn't necessarily have to be tied to these issues that were found to be priority health issues. And as we'll go into a bit later, a very small amount of total community benefit spending nationwide, and it looks like same thing in Ohio specifically, is for what you might think of as direct community benefits, as in money that's either given to local organizations or used to create health programs, clinics, health education, anything like that. It's a very small amount of the total. And tying to what we said about, what I just said about the fact that there's no minimum, this was an interesting lawsuit that was sort of covered in modern healthcare when Sutter Health was being accused of not devoting enough to financial assistance, the free discounted care. And what they said was, we don't know of any federal requirement that we have to even give any amount of free or discounted care. We just have to have a financial assistance policy and we have to report it. So if we had, they said basically we had a financial assistance policy and no one fell under that policy, no one was eligible, and we gave no money, there is no requirement for us to do so. And they're kind of right, which is a little bit, is very interesting. So this slide is from Community Benefit Insight, which is a great resource. And this is just a graph of the proportions of the total community benefit spending that hospitals in the US have done and the different categories of it. I'm not going to go into all these categories, but I do want to note that the big purple block, the biggest one, that's Medicaid shortfall. And the orange block right above that, that's also pretty big. That one's health professions education. You'll see the pale blue block above that, that's financial assistance. That's also a pretty big chunk. And then all the lesser chunks, you have research in there, you have the community health improvement activities, you have subsidized health services, but these three chunks here are really just the vast majority, and Medicaid even by itself is just huge. So when we were creating a ranking of hospitals based on community benefit, we thought, do we want to include every single category that the IRS allows, or do we want to be more specific about what we consider to be meaningful community benefit that hospitals are providing? And we decided we wanted to be more discerning. So rather than include Medicaid shortfall, shortfall from other government programs, health professions, education, and research, we were going to focus on the types of categories of spending that we thought were more directly meaningful and impactful on actual community health. So that includes charity care or financial assistance, which is the free discounted care. It includes community health improvement activities, which are programs that the hospital undertakes, maybe health education programs or diabetes clinic or free blood pressure testing, anything of that sort that directly impacts health in that way. Community building activities, those are activities undertaken to address the social determinants of health, sort of upstream factors like affordable housing or even community advocacy and organizing is included there, I believe. Contributions to community groups, that's pretty straightforward. And subsidized health services, which are the lines of service a hospital maintains, like it could be even like maternal care or addiction care that don't actually make the hospital money, but they wouldn't exist if the hospital didn't provide it. And maybe Vikas, you can go into a little bit about the categories we don't include and why we don't include them.
Yeah, I mean, it's a long conversation. We don't include health professionals, education, or research, not because we don't think those are important. They're obviously critical and they're public goods. For us, it's mostly a question of how should we account for these and at what level. And there's really not a good, clear, transparent way of answering this question until we have greater clarity on what's included. So for example, research is quite often taxpayer funded, or if it's funded by philanthropic donations, there's already a tax write-off in place. So we wanted to avoid the sense that there could be a double tax avoidance by giving hospitals credit for these, as well as the individuals that are contributing. Health professionals education, there's several funding streams for health training, and they're primarily in Medicare. And our view was that this is an important dimension that needs to be addressed in its own right and on its merits. Certainly, if both research and health professionals education were more closely linked to the communities that hospitals serve, either in the way of the needs assessment or in terms of how the research agenda is set, or how slots for health professionals training are determined on the basis of community need, it would be a very different conversation. Medicaid shortfall, one of the fundamental bricks in that, and a core focus of both the report that Loren mentioned and of the work of the Institute, I'm talking about Community Solutions, not the Lown Institute, is really about whether or not the amount of money that's being paid, which is certainly much less than commercial payers or Medicare, but whether the amount of money being paid represents a loss or not. And that's purely a function of the cost structure of the hospital. It's an insurance that doesn't provide the same amount of money as other insurances, but we don't really consider Medicare shortfall as a community benefit. And there are discounts being given to commercial insurers. We don't count those as necessarily a community benefit. So the question on the table is really whether or not Medicaid shortfall is something that warrants a local community giving up essentially not enjoying the benefits of tax proceeds. And we believe the answer is no. There's a long discussion we could have about it. Before I leave this topic, let me just say that we're not really outliers on this as an organization. It turns out, though we didn't design it this way, that the Commonwealth of Massachusetts and a couple of other states basically do what we're doing. So it's really a question of how you look at the world and what you think is really important. So here's a question for the audience. Which types of community benefit are most important for you of the ones that we showed? Maybe we can take a look at that and see what pops up in the chat. And let's continue. So at the Lown Institute, as we did this work, we began to ask this question because we wanted to understand really, in terms of direct community benefit, is there a gap? Which hospitals overperform? Which hospitals underperform? What is the landscape? So we developed a term which we call the Fair Share Index, which measures the direct community benefit that we report in our rankings and compares it to the tax benefit or taxes avoided by nonprofit status. So this is how we do that. We look at the tax exemption, and in the first iteration of this, we used a blended average around the country of an estimate of what that is, 5.9%. So this is a blunt instrument, granted, but it's a first iteration. What we counted are the things you see on the left. And we're now actually doing work that locally in various localities, New York City, for example, and we're talking to other municipal and state authorities. We can tune this estimate directly to the tax rate of the individual locality, and we're doing that. So these are much more precise fair share estimates. But using this method, this is what we found. These are just systems, multiple hospitals gathered into systems, which is, a big trend in American healthcare for those who may not know that. And so looking at nonprofit systems, we found the cumulative result was a fair share deficit of about $18 billion. That's pretty substantial. I mean, in the era of trillion-dollar deficits, maybe not, but certainly for any locality, the numbers are actually pretty large, pretty meaningful. And one can really have a field day imagining what closing that gap might do to social determinants of health, various elements of healthcare that are underfunded because there's really just not enough money in them. These are the top 10 fair share deficits from our ranking. It speaks for itself. The numbers are significant. And The Cleveland Clinic is there at number 4, but there are really many all over the country. And in some ways, I have to invoke Flexner. In some ways, this is the system that's evolved. Academic medical centers, all sorts of drivers of how we got to this point. But it's really worth asking whether that's sufficient now. So the clinic in particular, when we looked at this, we estimated the value of their tax exemption was on the order of $900 million. And the meaningful community benefit spending was close to $300 million. So that's a substantial deficit in terms of direct community benefit. Many of you will know this has gotten a fair bit of play in the local media. I know the local NPR station and Cleveland Plain Dealer both asked these types of questions and covered it. And we're in the midst, as I said, of developing a customized report for New York City, commissioned by a union health fund. So this is a fund that pays for the health care of union members. And so, to use a hackneyed phrase, they absolutely have skin in the game. And so they're interested to understand not just what's going on with their costs of care, the pricing, but also what are the other elements at play in the hospitals in their community that might afford opportunities to improve community health and improve the health of their members. So we're working on that. This involves calculations not just of federal and state taxes, sales taxes, local property taxes, as well as the rough estimate of the difference between being able to sell a tax-exempt bond and a taxable bond in terms of how much financial benefit there is. So that's what we're doing for New York City. These are the different metrics. It's based on work of colleagues at Johns Hopkins, but I think we're now iterating it in a way that is specific to what we do at Lown. So, Judith, how do we increase transparency? How do we get things more accountable?
Yeah, and again, if you have ideas in the chat, please throw them in. We're already getting some great ones. I see something about the Cleveland Clinic's Lead Safe Home Fund, which I'm really glad to hear about, because that's a recent development that they've just decided to invest, I think, $50 million into, which is just so fantastic to hear. That I don't know if it's related to the attention they're getting, but if it is, great. And if it's not, also great. Okay. So there's obviously a lot of things I think the IRS should be doing too, and I can go into that later. But in terms of a maybe more local level, a lot of states have changed up how they require hospitals to report their community benefits. For example, like we said about Massachusetts, they require hospitals to submit a community benefit report specifically looking at the community benefit activities that are designed to address the needs found in the health needs assessment. So these are the only ones that count. These are the only ones we care about. Report these to us. It's also been proposed, and I think this is a great idea, that hospitals should report how much the value of their property is worth throughout. This is often publicly available information, but it's hard to get across all hospitals in an area. So it'd be nice to just have that. How much are they gaining specifically in property taxes, since that's what could go to schools and other local issues. Some places have done a spending minimum, thinking mostly Oregon has a very novel spending minimum where it's tailored to each hospital based on their financial position, based on their previous charity care and community benefit. So I think that's really interesting. I'm excited to see how that, it's early years in there, but I'm excited to see how that turns out. I think there's a fear among some people that the minimum will just be a floor and everything will just drop to that floor. I don't know. We'll see what happens. And then community control and community engagement in these processes are extremely important. I know a lot of you all on this call are very experienced in developing health needs assessments, and you're used to having community participation, and you know how important that is, and the extent to which I think that can be better enforced so that it's happening like really well across all levels would be really fantastic. And then on the other hand, how much control does the community have over the outputs of that, the money that's actually spent to address these issues? I think there's been the idea of, what if all hospitals pooled all their community benefit funding and it was under, a community-led board that decided where it went? That'd be pretty interesting. Another thing, as you said, something that our colleague and fellow Paul Haddis, who's done a lot of work in Massachusetts on community benefit, it always says that it's a little peculiar that for most public health and medical issues, we're looking at the outcomes. We want to know how much healthier did people get. But for community benefit, because it's like more of an accounting and legal metric than a health metric, we're only looking at the inputs, like what did you spend? And for the outputs, there's not really a good way to know, okay, well, how did this help your community? So making sure that we can measure both of those is really important. And then something else that, New York is considering, there are a lot of areas in which the state has some control over hospitals, maybe not like a lot, but regarding, a certificate of need laws or any other situation where the state has to approve an expansion or something else a hospital wants to do, that could be a good opportunity to say, all right, well, you're going to expand, but, do we really want this hospital to expand if they're not devoting enough to meaningful community benefit? Or okay, you can expand, but you have to increase your financial assistance eligibility up to X level, the federal poverty level. This is actually what Connecticut did when I think Yale New Haven wanted to acquire another hospital. They said, okay, you can acquire this hospital, but now your community benefit spending, they set a minimum level for them.
Great. Let me just chime in on one or two things. I think this idea of community benefit outputs is interesting, particularly after we heard from many people recently about the Cleveland Clinic agreement to fund a de-leading program. And with Dr. Margolis here on the call, I think there are ways in which we can track that sort of thing. And certainly at the population level, there are ways of showing directly what that resulting population health benefit has been. Some might be modeled, others might not, but whatever it is, I think it would be very useful to start routinely thinking that way, because I think that would supercharge everybody's efforts to really try to address social determinants of health and community determinants of health. So that's what we have. We're happy to answer questions. I know there's a lot of activity in the chat. I haven't been paying as much attention as I should, but I'm going to hand it back over to you, Loren.
Thank you, Doctor, and thank you, everyone, for your participation and for that overview. I think, it's very interesting. Oftentimes when we talk about community benefit programs, we don't have the breadth and depth of what that actually entails from a policy standpoint, and what the potential is for greater collaboration between communities. I think, Dan Cohn from the Mount Sinai Foundation and Dr. Saini, you mentioned this, the type of investment that Cleveland Clinic made into a community health project like the Lead Safe Cleveland Coalition is definitely the type of thing that gets after a public health issue, that gets after a housing issue, and has some long-term medical and even behavioral health and even criminal justice benefit associated with it. So I think making those things transparent and distilling this is a part of the endeavor we have here today. So with that, I know Zach Schiller had a question about 5.9%, but if any of you have any questions, please put those in the chat. I will help sort of moderate those as they go. So if you have any specific questions about what you've seen here today, or if you have any questions just generally about community benefit, want to get into any detail about what some other states or other local communities are doing, we welcome those. Please put those in the chat. I'll kick us off though to start, if that's all right, Dr. Saini, and that is, so what do you see as being the best way to start this type of conversation? I mean, obviously, healthcare is a big industry in our state. It's the second largest behind agriculture. Hospitals are a big employer in our area, and obviously with that comes a lot of concerns about, well, how do you negotiate this relationship responsibly? And I don't think any policy development happens in a vacuum, right? You want this to be about collaboration. So are there any best practices that you could highlight about ways that these sorts of efforts are done in a mutually advantageous fashion, one that doesn't necessarily ruffle feathers, but one that feels like this is a good process. This is how we should be doing this work.
Yeah, well, our goal with the hospitals index and the work in general was really to provide various metrics and yardsticks that could serve that very purpose. But, they're not the answer. They're just a tool. The answer really lies in process. It lies in serious participation, engagement between civic leaders, state and local political leaders, and leaders of the hospital sector. That has to happen in a very open and transparent way. Healthcare is damn complicated. I mean, I don't believe it needs to be, but there's no question that it is. And so certainly there's a need for better information and a need for information and education in terms of community leaders and community groups. So I would say information, a period of education, and then serious engagement around what are the core needs. So that's the heart of a community health needs assessment. And I think what we really want is to build a consensus, not just within the hospital or within the hospital and its particular set of community members that they interact with or relate to, but a broader group of community leaders. And that process has to be managed. It has to be led. And that, really requires authentic, committed leaders. I'm sure there are many such leaders in the Cleveland area across, every sector and amongst all stakeholders. And let me say at the outset that, I have a lot of friends who are in senior leadership at hospitals. Hospitals want to do the right thing. They want to do this. They've got their own constraints. And so in some ways, there's a real opportunity for community leaders, hospital leaders to create alliances, to change the regulatory and policy environment. So the things that everybody would like to see actually now have policy wind at their backs, and they can actually do that. So without that, I don't think it's going to happen. It's not going to happen piecemeal. It's not going to happen one thing at a time. As much as those are important, they're just the start.
Yeah, I would say, since in the past couple of years, even especially with COVID and with, Black Lives Matter and everything, hospitals are really motivated to prioritize health equity. And, spending their fair share on community benefit is really important for that. And so I think, and in the conversations that we've also had with people at hospitals that manage community benefit programs, who are not necessarily the leadership, they're doing the work actually. They would say things like, I would love a bigger budget because, as we said, we're measuring the inputs, we're measuring how much is going into these. So I think the folks that manage it would love to have more to do with more. And it's a matter of getting them on the same page with the leaders of hospitals to make this a priority as well in terms of like accounting and budgeting, how we're doing that.
Yeah, so it all starts with the conversation, right? I've definitely heard before, and we've had conversations here at Community Solutions, particularly as it relates to Medicaid, that Medicaid just can't pay for everything. If we know that housing is a challenge, you have to pay for housing. If you know that food insecurity is a challenge, you have to address food insecurity. There are connections that can be made through policy, but part of this is about starting that conversation because I think like both of you are alluding to, there are people who want to do this the right way and, involved in systems where it's just all about being collaborative and having that sort of mindset. So we have a couple of questions in the chat here, and I'll start with Zach Schiller and then get to Ben's question. So Zach asks, what role do you see for pilots, payment in lieu of taxes, and how do they factor into your research?
So I'm going to let Judith address a little bit about what she knows in that area. But let me just say, for me, I think pilots represent an incremental effort to do something, but I don't think they represent the kind of vision on the horizon you want to go after. So I think what you really want is to think about that vision, understand where you want to go, and then the way stations on the way, such as pilots, if they're in the proper context, could be very, very important and meaningful. I worry that they might, for various reasons, A, they're voluntary, B, they're narrowly construed as to what represents the dollar figure, all of that. I worry that they just become a sort of temporary fix that's permanent. As Dr. Lown used to say, there's nothing more permanent than a temporary solution. So, Judith?
Yeah, so I think, their money going back to the community that they need, that, if you're not paying your fair share, give the rest of the money. It is money, so it is something. I like it. But I do agree with the cost, in where it's been implemented. I know that Boston has a voluntary pilot payment system, and the voluntary payments they're asking are really not much compared to their fair share deficits, and they're not even paying that. So I think a little bit of it there has to be some kind of oomph behind it, especially if they are voluntary. Who knows what you're really going to get there, how they factor into our research. So they're not included in our fair share deficit analysis. So to the extent to which hospitals are paying that, you could shave maybe a little bit off there. Although, I've been looking at this, and there's not a lot of great compilations of hospitals paying pilots to the city in this way. I think the last thing that was published on this was in 2012. So really, we need more research on this. Take a deeper look into this.
But my impression is it's not a very extensive group, right?
I don't think so. No.
Yeah.
Thank you. Next question for Ben. As you're alluding to, I think people forget that investing in the community in collaborative ways across hospitals will require infrastructure, people, and organizations to make work. Someone or some organization can bring partners together and administer funds. This is a step I believe people forget to invest in. Are there models across the country for infrastructure to bring community leaders together to collaboratively study and invest in communities?
Well, there aren't models that are really specific to this. Loren, you're probably as much of an expert as anybody on this, but I don't think there are specific models for this, but there are many experiences that are similar. And I think, Americans are very inventive and very creative, and I have no doubt that, the right people coming together could, figure that out, or at least a first iteration. There are various aspects of it, certainly community engagement. The Oregon model, which, insiders know all about in terms of assessing how you prioritize certain health needs and how you fund them, is a version. There are other models around the world that actually are similar, where they actually seek community input and even some degree of community sort of authority for those decisions. So I think we could figure it out. While we have time, I just want to take a minute and editorialize about something. And you can blame me as the cardiologist or being the doctor here. But there's a point at which we want hospitals to take care of people who are sick. That's their main job, right? Their main job is not to provide housing. Their main job is not to deal with food insecurity. What we're saying is it ought to be part and parcel of their work, but it's not the lion's share of the work, and everyone needs to understand that. And I think community leaders and political leaders also need to understand that they can't use hospitals as a piggy bank for all sorts of things. So we have to get real about this. Having said that, the fair share deficit numbers speak for themselves. And if you want to start imagining what you might do with even 10% of that in the Cleveland area, you're talking serious money.
That's an excellent point, Dr. Saini. I think too, the thing we want to avoid in this conversation is somehow typifying any institution or any healthcare provider as being any specific way. Broad generalizations are not necessarily good. But it's about having a creative conversation around common problems. And I think Dr. Margolis's comments about some of Cleveland specific challenges that we have, this is just part of a larger tapestry of options that collaboration can help sort of address. One thing I wanted to ask all of you to that point is, we've seen some information come out recently about some of the financial challenges of hospitals. And obviously, these things ebb and flow because with COVID, we saw utilization go down, insurance companies had much higher margins, and we can get very nerdy very quick. Things may change over time. We're already seeing an uptick in staffing around hospitals, but obviously the economic challenges of hospitals are well known, particularly in a place like Cleveland, where we just saw one system close most of its services. So how do we balance the sort of economic input that hospitals do create and the challenges they may be facing with the efforts that we're talking about here around trying to reimagine what community benefit policy may look like on the local level?
It's an excellent question, and the reason it's excellent, it's a tough question. Let me just say I've seen some spreadsheets, from first half of this year, and yeah, they're kind of scary. And so I don't think we should minimize the challenges hospitals face. Essentially revenue is flat-ish or maybe up a little, a few percent, but costs, particularly labor costs, both current labor and then definitely the travelers, primarily nursing, has gone up double, triple. And, these are serious numbers. And with small margin operations, that's enough to tip you into the red. So there's no question that's happening. And then the supply chain is another dimension. Finally, the stock market decline, a lot of hospitals have been, investing pools of cash. I'm not sure people fully understand how that is, but I know hospital execs understand that, both the hospitals that have large pools of cash to invest and those that don't. It is a factor. And so the decline in the stock market has also been a double whammy. So recently, for example, in the state of Washington, just I think last week, we're talking about a swing from black to red of $2.5 billion across the state. Big numbers, serious numbers. The way I think it's important to look at that is as follows. It's clear that hospitals will need, some changes, some, forbearance in various ways, changes in how their things are done, potentially some funding support. But I don't think any of those things should be done without reference to the very issues we've been talking about. The hospitals with the lowest margins tend to be in poorer communities. They tend to serve poorer people or minority people. Those are the ones that are going to get hit the hardest. So if we're going to have relief, financial or regulatory or whatever, there has to be some recognition of that fact. We can't really, do what we did with the first round of the CARES Act, where everybody just got their pro rata share based on their Medicare revenue. But the hardest hit hospitals were not necessarily those. So we need to be smart, and we need to include these concerns and issues in those conversations because they're undoubtedly looming.
Yeah, and I would say seeing some of the recent hospital closures and issues on this, it is a little bit scary, like Vikas said. I know there was a hospital in Cleveland, St. Vincent's, which is closing its inpatient, I believe. And that's a safety net hospital. So that's pretty impactful for the community. To me, this really just shows that how messed up our system is, that hospitals aren't really paid to keep people healthy, and they're paid the most to do elective procedures on people with private insurance. And that's not, and when you have something like COVID, where everyone's getting sick, regardless of their insurance, and they don't need elective procedures, they need emergency care. Hospital finances can sometimes be really hit really hard. And I wonder if things get bad enough, can hospitals kind of join with community advocates, join with folks like us to demand that we change how hospitals are paid, so we can change the payment structure so that hospitals are actually paid to keep people healthy. And I think that would also change kind of how hospitals approach community benefit. Much bigger incentive for hospitals to join together with community members, with each other, and say, how can we have the most prevention if they get paid to keep people out of the hospital in the same, like as much as they would be to, fix their knee or something like that. I know that's much more nuanced in the way I've just said it, but something along those lines, I think would be great.
a really great point. And obviously, I think this topic and the reason we invited Dr. Margolius here sort of underscores that point that, an ounce of prevention is worth a pound of cure. But, that also means a lot of dollars and cents in a lot of ways. Fee for service and the system behind it has incentivized more acuity, more institutional based care. And there's a transformation happening. So this is a part of that effort to manage that transformation. With healthier communities, you get healthier communities, for lack of a better way to describe it. So with that, I know we have a couple minutes left. I don't see any more questions. I want to first thank Dr. Margolius for joining us today and offering his insights on the good work that the city is trying to do. I think he's had a number of challenges between COVID-19, monkeypox, and then just trying to manage all of our other challenges here. But if you haven't signed up for any of their social media, apparently that's a very good and important thing to do, that they can become a reliable source of good information. And then also, I want to thank Dr. Saini and Judith for joining us here today from the Lown Institute. If you're not familiar, again, the information they produce is impeccable, really helpful and insightful. You can look up information on your local hospital and other communities and what they're doing. I'm very excited to hear about some of the more localized research that's coming out. And of course, we'll make sure that our slides are out and that everyone gets a copy of those slides and a link sent to them after we conclude here today. But I want to thank also all of you for attending and for joining us. At the end of the day, what we're interested in here is improving, the health outcomes and the economic well-being of our community. And this is just one place where maybe some policy conversation needs to be had. And I think that if we bring partners together to do that in a meaningful way, that we can do that in a positive fashion. So thanks all of you. Thank you again for our presenters, and please have a good rest of your afternoon. And don't forget, visit www.communitysolutions.com for all your local policy needs. Thank you. Have a nice day.